All right, thank you for having me to present our work. These are our disclosures. Dr. Funk is supported by a Career Development Award from the ACS and from the VA. Every year, approximately 10 out of 100,000 people in the US develop achalasia, with dysphagia as the hallmark symptom, among others. Primary treatment includes endoscopic 30 millimeter pneumatic balloon dilation, laparoscopic Heller myotomy, and more recently, per-oral endoscopic myotomy or POEM. Patients who undergo myotomy typically have good short and long-term relief of their dysphagia. However, approximately 15% of these patients will have recurrence of their dysphagia and seek further care. Both pneumatic dilation and POEM have been described to treat recurrence of their dysphagia after they've undergone primary myotomy, but no head-to-head comparison of the techniques has been performed. Our objective for this study was to compare patient outcomes between pneumatic dilation and POEM for recurrent dysphagia after primary myotomy. We used a database containing all patients who underwent foregut surgery at the University of Wisconsin in Madison and selected all patients who underwent myotomy for achalasia between 2013 and 2021. Within this group, we identified all patients who underwent pneumatic dilation or POEM for recurrent dysphagia. We then compared demographic data and pre- and post-procedure Eckert and GERD health-related quality of life scores of both groups using Fisher's Exact, Wilcoxon rank sum, and t-tests where appropriate. Between 2013 and 2021, 1,892 patients underwent foregut procedures at the University of Wisconsin. 103 of these patients underwent myotomy for achalasia. Of these, 19 underwent pneumatic dilation or POEM for recurrence of their dysphagia for an overall myotomy failure rate of 18.5%. 10 patients underwent pneumatic dilation, while 9 patients underwent POEM for their recurrent dysphagia symptoms. Mean follow-up time was 1 year. Demographics and achalasia subtype did not differ significantly between patients who underwent pneumatic dilation or POEM, though the patients who underwent POEM were heavier than those who underwent pneumatic dilation. Most patients in the study had undergone a laparoscopic Heller myotomy as their initial treatment for achalasia, followed by thoracic myotomies and POEMs. Most patients had anti-reflux procedures performed with their index myotomy, consisting mostly of anterior fundoplications. Patients in the PD and POEM groups did not differ on the type of fundoplication. Both pneumatic dilation and POEM groups saw overall improvements in their dysphagia and GERD symptoms as evidenced by decreasing Eckhart and GERD HRQL scores. However, only patients who underwent POEM had a statistically significant difference in pre- and post-Eckhart scores. The mean change in Eckhart and GERD HRQL scores was not statistically significant between groups. The rate of dysphagia symptom resolution, as defined by a post-procedure Eckhart score of less than or equal to 3, also did not differ between groups. Overall, 11 out of 19 patients had resolution of their dysphagia symptoms for an overall success rate of 58%. Patients who underwent pneumatic dilation experienced a much shorter average procedure time compared to those undergoing POEM, as well as a shorter hospital stay, with the majority of patients going home on the same day. Most patients underwent POEM had an overnight hospital stay. There was one adverse event in the pneumatic dilation group, which was a perforation which required stenting, and there were 3 adverse events in the POEM group. One, a submucosal tunnel bleed that required EGD and clipping, one submucosal tunnel dehiscence, which required washout and tunnel closure, and then one esophageal obstruction secondary to a submucosal tunnel hematoma that required dilation. More patients in the pneumatic dilation group required additional pneumatic dilation, and 2 required additional surgical procedures for their symptoms, which consisted of a POEM and an esophagectomy, respectively. Of note, 2 patients within the pneumatic dilation group required up to 3 additional dilations for persistent symptoms of dysphagia. This is the first study to compare pneumatic dilation and POEM for the treatment of recurrent dysphagia after myotomy for achalasia in a head-to-head fashion. The outcomes of both groups are relatively similar, with those who underwent pneumatic dilation enjoying a shorter procedure time and hospital stay at the expense of a higher likelihood of needing additional procedures, most of which were repeat dilations, and ultimately additional surgery for a few. Traditionally, revisional surgical myotomy and pneumatic dilation have been used as first-line therapy for recurrent dysphagia after myotomy. Revisional surgical myotomy can provide long-term symptom relief, but with a lower success rate compared to primary surgical myotomies, and carries with it the risks and complications of revisional foregut surgery. For this reason, endoscopic interventions are an attractive alternative. Primary pneumatic dilation has a success rate of 60%. This rate's lower when performed after primary myotomy, and patients are likely to require multiple dilations for symptom control. Given the risk of perforation that is inherent in each dilation, enthusiasm for using pneumatic dilation in these patients is low. More recently, POEM has been proposed as a treatment for these patients. The published success rates of POEM after failed myotomy are 80 to 90% with short-term follow-up, which is a higher rate than we experienced in our series here. Overall, this rate is lower than POEM for initial achalasia management, as it is with primary surgical versus revisional surgical myotomies and with primary pneumatic dilation versus repeat pneumatic dilation. This demonstrates that revisional procedures after primary myotomy are generally less effective than primary treatment, regardless of the technique used. The results from our study have to be interpreted with caution. Achalasia is a relatively uncommon disease, and failure after initial myotomy is even more rare. This makes for a very small sample size, and so drawing inferences from our results is inherently problematic. Additionally, these are non-randomized observational data analyzed in a retrospective fashion and don't contain objective outcomes data like post-myotomy, manometry, or endoflip data. Many of the Eckhart and GERD HRQL scores were collected after additional procedures had been performed on these patients to treat dysphagia symptoms, and so that may have impacted and confounded our results. We also couldn't fully capture other reasons for persistent dysphagia like a tight crural closure or malpositioned fundoplication with our data. That also may have affected our functional outcomes. Lastly, we weren't able to universally capture endoscopic dilations of 20 millimeters or less, and so these were not included in our analysis. In conclusion, patient-reported outcomes are similar for both pneumatic dilation and POEM when used to treat recurrent dysphagia after myotomy. POEM might provide an alternative to pneumatic dilation with the advantage of lower number of additional procedures at the expense of longer operative times and longer hospital stay. Thank you. I'll take any questions.